Good afternoon. Very, very warm welcome. Just going to give everybody a moment to just settle into the space. Very lovely to have you all here this afternoon. We've got more people coming in and we'll be starting in just a moment for the webinar this afternoon. Hopefully you can all hear and see me and you can see the slides here on the screen nice and clearly. Okay, so for those of you that are in the room, I think we will just get going in terms of the initial introduction, and we'll have people perhaps joining us as we begin to do that, as we have quite a bit to get through over the next hour. A very good afternoon again and a really warm welcome. This is the sixth webinar in the series that we've been delivering as the Integrating Our Mental and Physical Healthcare Systems team, and this work really is an important opportunity for us to showcase much of the outputs of an important programme that has been funded by the Maudsley charity over the last 3 years. Our work together really has been thinking about how we can identify, test and evaluate physical health interventions that can improve the lives of adults living with serious mental illnesses. And through this webinar series, we've really been trying to guide you through individual projects in our portfolio. And we've invited clinicians, researchers, project managers, and experts by experience who have worked with us to share their experiences, learning, and ideas for the future in terms of development of this work. Now, my name's Gracie Tredgett, and for those of you that don't know me, I'm the current project manager of the IMPHS project. So it's really my pleasure to be here with you this afternoon. And what I will be doing is guiding you through, as I said, the very last webinar, which for us, we'll be thinking about delivery of a 2-year pilot project that has been focusing on delivery of an in-reach physical health service delivered by a consultant physician from King's College Hospital. And we've delivered that in mental health wards at Maudsley and Lambeth hospitals. So our aim today really is to share with you the impact of this work and how we've evaluated that with the support of the Centre for Implementation Science at King's College London. So what I'd like to do is just share with you a little bit about the agenda. What we've got covering kind of in today's session is a bit of background and rationale. We'll be welcoming Fiona Cochran in just a moment to be able to give that for us as to why this work has been seen to be so valuable and important and what we've been able to do through this work. But also in addition, of course, we've got lots more coming up in terms of those that have been involved in delivering the evaluation and getting some feedback from key people that have been involved to help us deliver this work in terms of the difference it's really made clinically and what we hope it will go on to be able to do as we continue to learn from this work. There will be a chance to ask us questions as we go through. As ever, we do record these sessions, but we do actually invite you really to keep talking to us as we journey through the webinar. So please do put comments, questions in the chat function. If we can answer as we go, we certainly will do so. But also there'll be a chance at the end for a brief Q&A. If there's any real burning questions, we think it would be good to discuss with key speakers who have joined us today. That's all that I would like to say at this stage, other than, again, for those that have just slipped in the room as we've done the initial intro, huge welcome. And I'm now going to hand over to Fiona Cochran, who, as I say, has been integral for this particular piece of work, not only just generally in terms of IMPHS, how we've been delivering this programme, but as lead consultant psychiatrist at SLAM and professor of physical health and clinical therapeutics at King's College London, Fiona really has been a key colleague and peer and given us immense guidance around how we should be delivering this. And it will be lovely now, Fiona, to have you share a little bit about the background and rationale as to your involvement with this work. I'll hand over to you, Fiona. Thank you so much.
Thanks, Gracie, and thank you very much for your kind introduction. And it's actually been wonderful to be able to come and tell you about this. And it's been a great experience to work with the team and with our colleagues and with our service users to bring this to fruition. So this is the next slide, please, Gracie. Just, I think if you've attended the previous seminars, webinars, you'll know how disadvantaged people with significant or major mental health illnesses are in terms of their health outcomes, and of course, and people are aware of the mortality gap. But it's just, this is a nice slide that came out of the King's Fund about 10 years ago now. But they are estimating that comorbid mental health problems are very common, so that 30% of people with a long-term condition have a mental health problem, and they're often looked after if they need mental health input through the general hospital system by liaison psychiatry. But on the flip side, 46% of people with a mental health problem have some form of long-term physical health condition. And we haven't got systems in place or services in place routinely to help them manage their physical health care as well as they might. And this has economic consequences as well. It's reckoned that total health comorbid mental health problems raise total healthcare costs by at least 45% for each person who has both a long-term physical and mental health problem. Next slide, please, Gracie. We got together across the world. This is a universal problem, poor health outcomes, and how do we bridge this gap? And we did a commission as part of Lancet Psychiatry, and from many different countries, and looked at the commonalities. And you'll see the important points such as high rates of smoking, which is probably the biggest reversible risk factor. Being careful that with prescribing that it's effective and what you want to manage with minimal side effects. But at the bottom half of this one slide blueprint, you'll note the fragmentation of services. We're operating services in parallel, and it's very difficult to get your mental health services from the physical health system, and challenging to get your physical health services when you're in the mental health care system. So we asked for people we made the call to make that better, to increase access to integrated services. Next slide, please. We did a little evaluation using observational data about this, which we published in 2015. The data we had was based in 2010 to 11, and we counted up how many hospital admission episodes in mental health involved a stay or a trip to a general hospital during that time. And over a year, 10% of psychiatric admission episodes included at least one night in a general hospital, and 12% of episodes included one trip to the emergency department. And when you and obviously some people were admitted more than once. So of those people who were admitted at least once, 16% of them over the course of the year ended up spending a night in a general hospital, and 18% at some point over that year went from our psychiatric hospital to the emergency department. And this is really highlighting, is there something we can do better to be able to help people get care where they need it without having to sit and wait in the emergency department, or potentially avoid being admitted to a second hospital and then having to come back again, etc. And the interruptions to care and comfort and quality of life that produces. Next slide, please. This was done at a bigger level by the NSIPOD, the National Confidential Inquiries for Patient Outcomes and Death. This was published last year as part of a huge big survey, and they've made a number of key messages here aiming to improve the care of people who are admitted to psychiatric or mental health inpatient settings who are also physically unwell. And you see that a lot of these are common sense, and taking advantage of this, of being admitted being a golden opportunity for intervention, the importance of creating a physical healthcare plan. Going down to number 4, the importance of involving patients and their carers and families in their physical healthcare, and using this admission as an opportunity to kind of have an MOT and make get to grips with people's physical health at the same time as the mental health is receiving treatment, and also having digital backup for that. Next slide, please. And just to highlight, I've just amplified message 3 here, which is probably very relevant to the work we're about to present here, is to create formal clinical networks and pathways between mental health and physical health care, and recognizing that mental health care staff do need support in providing effective and up-to-date physical health care. But when we surveyed people, we surveyed 268 mental health care professionals, and less than half reported feeling, just under half reported feeling fairly or less than fairly confident in or competent in caring for people with long-term conditions. And only about a quarter reported having local care pathways or pre-existing arrangements with physical health care providers as part of, to be used routinely as part of their care plan. And I don't think that anybody has quite set up the model that we are about to hear about now. So next slide, please. And that sort of sets a little bit of a scene, the need and the sort of national call for improved systems to be able to help with access and uptake of care. And we're looking at this for inpatients in our mental health trust. And the idea is to get better access to physical health care and to reduce unnecessary usage of and delays waiting for specialist medical input. So I'll hand you over back to our IMPHS team, and thank you very much.
Thank you, Fiona, so much. And I think what's so helpful in having you really set the scene on this particular piece of work is really the value in thinking about the pathways and the movement and how we actually support patients to access care in a really timely way that can support their whole health. And I think you're completely right to frame the fact this intervention has been a real opportunity to put that thinking into practice and to really test how feasible that really is in real time within a complex, large mental health trust. How do we do that with our patients? And so it's lovely to have your perspective, and thank you so much for being a part of this today. I'm really pleased now to move us forward into this next part of today's webinar, which is really at the heart of how we have delivered the physical health clinic and the implementation and evaluation of that within SLAM, which has been, of course, our area of focus as the IMPHS team over the last 2 years as part of this pilot. And because of how we have delivered this and the way in which it has been evolving over the course of those 2 years, we really wanted to be able to spend as much time as possible to share it with you as part of the webinar. So I'd like now to bring Ray McGrath, our lead nurse for IMPHS, and of course Dr. Julie Williams, who's our lead researcher, to now lead us through the implementation and evaluation of the clinic. I'll hand over to you both now. Thanks so much.
Thank you, Gracie. Yeah, I'm obviously I'm Ray McGrath. I'm going to kick off talking about the implementation and evaluation. Next slide, please. I think where we are at now with the clinic and where we're about to hand it over, actually now SLAM have just agreed. This was a charity funded project, of course, and now the trust have agreed to take this on. They've just funded for a further year in its current format. But I wanted to just go back and say where we'd come from, because the thing about this project is that it took an awful lot of work to get it going in the first place. So setting up the clinic back in 2019, so we're talking before the COVID-19 pandemic was around, we spent a lot of time coming together, scoping out existing literature, looking for reports, looking for anything we could get our hands on, basically, to tell us who else is doing something like this, where else can we learn from. We were attending conferences, we were attending kind of national forums and speaking to colleagues in similar settings with similar kinds of aims, and we spoke to 3 or 4 kind of key areas that probably matched what we felt was going to be the best approach for SLAM going forward. I haven't put it on the slide here, but the Whittington Hospital has a similar service, and you can find information about that online as well. A similar kind of in-reach service that they shared a lot with us about. That was their external work, but then internally, getting getting it right internally, understanding the local context is so important as well. We spent a lot of time speaking with patients, carers, and staff. What is it that they wanted this clinic to achieve? How was it meant to be run? And we did that in a number of ways. We did individual sessions, we had focus groups, we had theory of change workshops, we developed several process maps, and this period of work took about 8 months from start to finish as we were going through. Also worth talking about, before you set up a clinic or a service like this, there are other resource implications. So developing an SOP or your equipment lists, finding a space to hold a clinic in a busy hospital, even down to what does a referral form look like. And it took us about 8 months to kind of get to a really good place. And where that came to was the wish list, which was people wanted a clinic to be located on site. So patients in particular, they were saying, I'm in a hospital. I don't want to be moved to another hospital to go and speak to another doctor about another problem that I've got. Why can't the doctors come and see me? This is where I need to be. And we know that patients with who are admitted to mental health hospitals, they are acutely unwell whilst they're admitted, and being in the most appropriate setting, with that's potentially quieter or not as much going on around, not as many people watching or viewing what's going around, if they're having escorts to services or whatever, they wanted to be on site. There's a couple of quotes in there from patients that we interviewed as well, that I thought kind of spoke to this. Extended appointments, that was another key thing that came out. People wanted time to be able to go through discussions. So inpatient admissions generally, they aren't that long, and in the community, the access where people would go is primary care. But of course, GPs 10-minute appointments don't always fit the need for people that perhaps need a little bit longer to go through some of the issues that they're facing. The clinicians were saying they couldn't decide on one particular speciality that they wanted, so that a broad range of specialist input was something we were looking for. We wanted the clinic to be able to provide education and training as well, so we wanted this to be a developmental opportunity. Nurses are part of the care team. Sounds strange to be making that distinction, but although they might not be the ones that are making the referrals, they're the ones that are often delivering the care with patients on the ward. So referrals had to be easy, and not time consuming, quick response time. So, as I say, people aren't admitted necessarily for that long. A quick turnaround time, 2-3 weeks, wasn't feasible. And if the clinic wasn't able to respond to any of the queries, then they wanted to at least to improve the access to pathways. Next slide, please. So we did all this work and we came up with this great idea for a clinic, and we had a consultant physician and we had an advanced clinical practitioner, both with around about half a day a week, and to work on site at the Maudsley hospital. That was going to be our pilot site. Parents, carers, clinicians would book an appointment slot, which would be up to 45 minutes in length. They'd all go down together and be part of this kind of formulation discussion with the patients there. We'd got a room on the site as well, and it was all going great. And then just at the point of launch in March 2020, COVID hit, and it knocked us all off. So we lost the space. Half the wards, or sorry, more than half the wards were disbanded and given over to King's College Hospital as overspill if they needed it. And so we evaluated, well, how do we continue to go forward with this work? So in June 2020, we launched the next best option, given that we couldn't do what we planned, and that was a virtual offering, which was effectively over Microsoft Teams, which the trust had been using for a while anyway. Referrers would send a referral via the electronic records, and they could request either a telephone, an email, or a virtual appointment. And then that helped us develop our protocol. So how would we evaluate the service? But we caveated that this was iterative process. So as you can see on the far right of the screen now, the February 2023, this is what we're left with at the moment. So we no longer have the ACP nurse input. We only have consultant. Only. That's great that we have the consultant for a day a week. Referrals can still be made via the electronic records, and usually what happens is somebody makes a referral and within 24 hours they get a call back to have a bit more of a discussion. Does that patient need to be seen? Does the consultant need to come across the road and have a look at the patient? Equally, if people don't want to write a referral, every day there's a time slot. I think it's 12 to 1 or 12 to 2 now, that people can call directly using a service called Consultant Connect, which was the topic of last week's webinar. That goes directly to the clinic's consultant. And then finally, what we started in June 2022, we do a weekly walk around on the Maudsley site. So we walk around 5 of the wards, and also we have a place of safety there as well, which sometimes, depending on the circumstances, has patients in it. And doctors kind of nowadays, they have a caseload ready and waiting to share and discuss any physical health problems. Now I'm going to hand over to Dr. Julie Williams to talk about how we've started to evaluate some of this work.
Thanks very much, Ray. Hi, everybody. Yeah, I'm going to talk you through evaluation and give you some of the sort of key analysis that we've been able to do so far. As you can see here, we have published a study protocol, and please do have a look at that. It will give you more details than we're able to give you today. But in the evaluation protocol, we have 3 main aims, and I'll just talk you through these 3 quickly. Firstly, we wanted to understand the process of implementing the physical health clinic. And I think it's probably important to say at this point that I work in implementation science, and so we've used a lot of implementation science methodologies and frameworks for this evaluation. So first of all, we wanted to understand how to implement the clinic. And what we did was we have recorded all of the implementation activities that we've undertaken as we've gone along, and I'll show you those in a bit more detail in the next slide. We also wanted to establish the acceptability and feasibility of the clinic. And just to be very clear that by acceptability, we're talking about how satisfied people are with the clinic. And by feasibility, we're talking about how suitable is the clinic for people in the context in which they're working. So this is for the referrers. And then the third aim, which we're not going to talk about today because we haven't really got time, is about understanding the economic implications of running the service. So what we're looking at there is like, how much does it cost in terms of staff time and implementation time, and what are the kind of cost implications for the clinic. We are writing a results paper, and there will be more details of that in the paper. So watch this space for that paper to get more information on the economic evaluation. Next slide, please. So, as I said, we recorded all of the implementation activities that we did as part of implementing the clinic. And then we used a framework that's used in implementation science, which is a framework which has compiled a list of 73 implementation strategies, which has come from expert recommendations. And as you can see, this was published in 2015, and there are 73 implementation strategies that are grouped into 7 implementation domains. And so what we did was we sat down, Ray, Ellie, who was our project manager at the time, and myself, and we mapped all of our activities onto these implementation strategies and then into these implementation domains. And as you can see from the table there, you can see which of the domains we used most often. And you can see that really the biggest 2 were relationship building and knowledge. Now, I think that kind of makes sense because a lot of what we were doing with the clinic was making sure that people understood what the clinic did, how the clinic worked, and what they could expect from the clinic. So there was a lot of working with people at different levels of the organisation within SLAM to make sure that people understood what the clinic did and how they could make referrals. Relationship building is key for anything you're trying to implement. And so that's been really, really important for us to do. And also giving people knowledge about how to use the thing that you're implementing is really important as well. And I think that we were really lucky when we started doing this for 2 reasons. Firstly, IMPHS as a project was already very well known in SLAM, so that really helped. People knew us as a team and they trusted us. But also, and I hope I'm going to embarrass him now, Ray has got great skills in doing this work, and they're often called soft skills and maybe aren't given as much emphasis as they should, but it's really important, and Ray has been fantastic at doing this work. So they were the 2 main things that we used. And I think the other important thing to say about this is that often they were a 2-way thing. So it wasn't just us giving knowledge to people, it was about building those relationships. And actually what that meant was that we were talking to people and we were asking people about their use of the clinic. part of that was we did qualitative interviews, which two of our junior doctors from SLAM who worked with us, George and Theo, did, and thank you to them for doing those. And after I've spoken, we've got a video of George talking about those interviews, so he'll give you a bit more detail about those. But also it meant that we, on an ongoing basis, we were talking to people, and it meant that we then got really good feedback from people about how they were finding using the clinic, and we were able to adjust and be flexible about how the clinic functioned, and I'll show you a bit more about that in the following slide. And then the other thing to say is the analysis was really important as well, because we needed time to understand, you know, what did it mean when we weren't getting so many referrals, what were people telling us that they needed, and how could we implement those changes. So let me, next slide please, Gracie, and I can show you that. So in this slide, you can see the number of referrals made from the launch of the virtual clinic in June 2020 until September 2022. Now, you can see from that we had a point in the middle from about January 21 to June 21, where actually for various reasons and things that were outside of our control, the clinic wasn't really up and running. So we didn't do very much kind of comms work then because we didn't want to be overwhelmed. But then we were able to relaunch the clinic, given a face-to-face option in September. Then we expanded to the Lambeth site in November. Then we added the clinic to the consultant collect line in February, and then we started weekly walk rounds in the Maudsley site in summer last year. And you can see that there's been an impact in the number of referrals made because of those things. And I think this is another thing that's been really key, is that we've been able to be flexible. We've been able to listen to the needs of our referrers, so that we can make sure that the clinic is as acceptable and feasible to people as possible. We also found out, we kind of thought this was going to be the case, but we found out that trainee junior doctors are the main referrers. And one of the things that we did was that we made sure that any communication that we did, we made sure that we repeated that when the rotation dates happened for the trainee doctors. They were typically in August and February, though that did change over the time of the pandemic. And you can see that we used repeat implementation strategies at those different time points. And then you can see in the graph at the bottom that the user numbers have grown in terms of people, both new people using the clinic and people who are kind of using the clinic more than once. So I hope this gives you a sense that we've been able to be flexible, we've been able to really be in contact with the people using the clinic to give us a really good idea of what people needed, so that we could make sure that the clinic was used as well as possible to kind of meet the need that was there as much as possible. And now I'm going to hand you back to Gracie, who's going to play you the video from George to give you some feedback for the interviews that we did.
Thank you so much, Julie. So I'm just going to change my screen here, and we're going to invite this video in now, as Julie describes, with George Gillett, who has very kindly offered his time and in the absence of being here today, is going to share his perspective on his experiences as part of the physical health clinic. So hopefully you can hear this as I play now.
Working in psychiatry, the problem of kind of physical health or managing the physical health of patients is really obvious for us and kind of really stark. And it's something we see every day, that these patients have kind of complex physical health needs. And that's also seen in kind of research evidence that we know that patients have a reduced life expectancy compared to the general population. But at the same time, there's this kind of paradox that we really struggle to access physical health services for these patients, who are probably some of the most needy and vulnerable patients that we look after. So working as a kind of junior doctor, we see this a lot, that it can be really difficult to access physical health advice and support for patients with psychiatric needs. So I became really interested in how we can find interventions or explore interventions to better get physical health support for patients in psychiatric settings. which is both the kind of practical problem of thing, I think, about how services are organised and often separated between mental and physical health at different sites and locations, but also, a really kind of pressing medical problem that has real health consequences for these patients. Yeah, I didn't actually have any experience at the clinic. I wasn't working on one of the wards where it was live, but I wish I had in a way. Working on the wards I was working, had lots of frustrating experiences trying to contact senior doctors at other hospitals to get physical health advice, and sometimes actually referring patients or transferring patients to A&E, probably unnecessarily, because it was the quickest and sometimes only way to get that physical health advice. Yeah, so we interviewed about 8 doctors, generally quite junior doctors, the kind of foundation year level or early trainee doctors in psychiatry, who are often the kind of doctors who manage physical health needs on the ward. And we discussed with them their experiences of using the physical health clinic. And they described that really it was seen as quite a good option for the kind of physical health queries that were about non-acute issues. So not the kind of issues that would need somebody to be transferred to A&E, but also issues that weren't maybe confined to a single medical specialty. So they might be complex or involve multiple different medical specialties. Perhaps the kind of issues that would normally be managed in the GP setting or by a kind of general medical clinician. These might have been kind of chronic health problems, perhaps abnormal blood results, non-urgent symptoms, or sometimes actually, quite often we doctors reported using the service for concerns about malignancy or cancer. So respondents kind of aimed to use the physical health clinic, and we're usually hoping for some kind of advice on perhaps formulating a management plan, thinking about perhaps changing medications or ordering investigations. But also actually we saw that doctors were often just looking for reassurance, and that doctors are very used to working in teams where they have somebody senior they can escalate concerns or queries to, but that actually working as a junior doctor in psychiatry, there's not really anyone to do that from a kind of physical health perspective. And they really valued that aspect of the physical health clinic. So in terms of the feedback that doctors provided about the physical health clinic, they reported that the referral was easy to make, it was a straightforward form, was simple and very quick to complete. And then thinking about the outcome of the referral, all the doctors said they were satisfied with the kind of service they received. They reported that the physical health clinic team were approachable, friendly, helpful, and particularly valued that the consultant was familiar to them. It wasn't this distant, unfamiliar consultant who they were getting advice from, but it was somebody perhaps they knew or had experience of working with in the past. They reported that they would receive kind of clear and detailed plans about patient management. And they reported that they always would follow these plans and act on the advice provided. And really kind of positively, the vast majority of respondents felt that this had a really direct positive impact on patient care and patient safety. They felt that physical health issues would be resolved quicker because of the physical health clinic. And that actually it kind of provided what they described as an expanded MDT, this sense that there was somebody now in the MDT who offered up-to-date physical health knowledge and senior expertise of who they could escalate these concerns to. There were some recommendations of how it might be improved. Doctors kind of wanted some greater clarity about exactly which patients or which patient cases should be referred to the clinic. And they also wondered if it could be better integrated with other sources of physical health advice, such as the Consultant Connect service or transferring patients to A&E. And they also wondered if the service should be publicised a bit more widely. But overall, the doctors really reported that it was a really valuable service, that it saved clinicians time, but most importantly, that they felt that it really made junior doctors feel safer and more confident in their work. Yeah, I think doing this project really highlighted to me that we need to think about how junior doctors can access physical health support and advice for the psychiatric patients they work for, because there is this real paradox that these are some of the most vulnerable and needy patients from a mental and physical health perspective, but yet it seems often that it's hardest to access the support for them. So I really think it's relevant to think for mental health providers to think about the routes that patients have to access physical health support. And that's not just for immediate or acute concerns. It's also for these kind of chronic, complex and multi-specialty physical health concerns that the patients might have. And I think this project shows that actually quite a simple intervention, just having quick and direct access to a senior physical health consultant can go a really long way. But also that there are kind of human factors things around that having a named consultant who's consistent, who's familiar with the junior doctors, but also who's just approachable and friendly, who provides time and advice that doctors can trust because they know it's not rushed, or they know it's somebody who's genuinely interested and invested in supporting patients with psychiatric problems. Well, that stuff can all actually really go a long way. And most importantly, it can have a really positive impact on patient care and patient standards.
Okay. So lovely there to be able to hear a bit from George, and in particular, not only his views in his capacity in the work that he's doing as a junior doctor within SLAM, but also, of course, being able to really gauge the experiences of others who are using the intervention in real time. And I think particular, from George's perspective, it was really helpful to hear that it gave more space and time for junior doctors to really think about the physical health needs of their patients within psychiatry and the value that intervention has really provided. I think it really is a really good opportunity now, though, of course, to move us on to the next part of today's webinar. And I'm really pleased at this point to invite Prash and Shamila, who have worked very closely alongside Ray in particular in delivering the interventions around the physical health clinic. So I'm going to hand over now to you both. Huge welcome, Prash and Shamila. Thanks so much, both of you.
Thank you, Gracie. Shamila, do you want to go first or you want me to go first? Okay, since Shamila hasn't spoken up, I shall start. Thank you for the opportunity, everyone. And it's been a very interesting experience. So I'll just bring up some points which Ray kind of helped put together as to what would be interesting to talk about. Why was I interested on working on this project? So this came about when Caroline Elston broached this with me a long time ago, before the COVID pandemic. And she said there was a need for building this rapport with Maudsley to look after patients who, and working as an acute physician here, I've seen patients in A&E who I think could have been better managed if they had the input across at Maudsley rather than having to be transferred across for an assessment. So it would benefit both sides to have this kind of service where we can work collaboratively to look after patients with physical health issues in a better setting, like everybody has mentioned earlier. So this new kind of thought and the kind of need for it kind of was what brought me onto this project. What's gone well? I think I second Julie in saying Ray's soft skills have been very valuable. He has a great organizational memory and things and networking and things which have benefited in building those connections with the people on the wards. Now Shamila as well, she's got good connections on the wards, which helps promote the service. So I think that's gone really well. Examples of referrals that we get, as George put it, mostly general medicine queries. Give me a second, I think someone's at the door. Hi, do you have a meeting? No, just 5 minutes. Yeah. So in terms of finding the kind of, so how do we kind of make clear what we offer is going to be a big challenge. And at the moment, what I have kind of suggested is discuss with us anything that you're not sure about, and then we can signpost you or give you advice, or so no referral is a bad referral for now. So that's how we are looking at it. And with SLAM now continuing the funding for the year, we can build this service and kind of let the doctors on the ward know that this is an ongoing service, so they don't have to be apprehensive about thinking about how to improve the service or what kind of referrals they would want us to see. So these are the kind of things which have gone well. Things which could get better, that's an interesting one. So when you're working an additional programmed activity outside your trust, things get complicated because your primary commitment is at King's, and there's always time commitments which need to be negotiated. What's suitable for Maudsley might not be something which my managers here at King's are agreeable with. So I have to thank Sean and Isabel, who have kind of negotiated some time which is convenient for me and which is suitable for clinicians in Maudsley, because we initially thought Wednesdays would be good, but then that's the day when everybody is at teaching, so that didn't work out. So we managed to move it to a Friday morning instead, which has worked quite well. So these are the kind of challenges that that exist, but that can be overcome if people work together. So that's great that George thinks that the service has benefited the junior doctors, and I do think that having that reassurance for junior doctors is a big plus. I don't know how we can capture that. I think Julie might have some idea on so the health economics data, great, but I think this kind of reassurance for junior doctors is a huge plus, and for them to think about patients' needs for physical health assessments is one of the biggest achievement that we can think of if this project is successful. All right, over to you, Shamila. I think I've spoken too much.
Just want to check. I think maybe we've lost Shamila somewhere in the delivery of that part, perhaps. Think maybe we might have had a technical problem there, which is a shame. I know Shamila's been kind of jumping in and out, maybe having some difficulty being on the wards, perhaps. Prash, is there anything else finally that you would like to kind of add at this point? Shamila might be able to join us in that time.
One of the things that we need to think very carefully is, since the Lambeth site is moving across, and that's an additional 5 wards, how we can replicate the same kind of service over there. It's going to double the amount of work we do. My concerns are that there is no backup when I'm on annual leave or study leave or whatever. So there are some issues still that we need to think about, and how we can overcome those.
Thank you, Prash. Thank you so much. And I think it's so helpful to be able to get a real sense of your experience, not only in as much as being able to deliver the clinic and what that has involved, but actually juggling that with other priorities and other parts of your remit and role, and the challenges of that. I think that's really key for us to be able to articulate and share actually how we've worked together to overcome and think about how we can deliver this in the best way, where it's simplified and streamlined, but the most effective intervention it can possibly be that supports patients fundamentally in terms of their experiences and their whole care. So Shamila has just come into the room, so I'm just gonna see, Shamila, how are you doing? Can you hear us okay? we've got just to a point there. If you're able to join us, Shamila, we can give you a chance to say a few words before we move on there. No, maybe not. That's a real shame, and we've come to time on this segment. So unfortunately, the joy of technology can sometimes be challenging, I know. So we will move on at this point, but Shamila, perhaps if you, when you are back with us, we might be able to pop a few words in the chat so people can hear a bit more about your experiences. But for now, what I will do, if it's okay, is move us on to the next part, which is just really to summarize a bit of the thinking as it has been shared through this webinar. So of course, Ray and Julie and Fiona and Prash and everybody who shared a bit on this today has covered so many different aspects of why this has been seen to be a valuable approach and intervention, and the different ways in which we've considered how we could approach this best and implement it best within the trust. And I suppose we wanted to be able to summarize some of the key thinking, so to really get to kind of clarify for you here what is seen, we feel, to be the most important key takeaways. And a few things to mention with this. The local context within SLAM was significantly important because we recognized that there was limited research and literature that really helped us to understand whether an intervention like this could make a difference. And so what this pilot has enabled us to do is to think a bit about what might an approach look like and how do we make that evaluation methodology fit in terms of how we want to be able to measure the impact that may be having and the difference that's having, not only to staff and how they're practicing, as you heard George was articulating and Prash was sharing with us there, but also the difference that's making for service users and how that could be improving the care and the outcomes that they are achieving in terms of their health. And also that actually the intervention itself is meeting the demand, that we're actually recognizing what people need and we're able to address that quickly and effectively through the intervention. But being able to deliver a clinic like this has taken time, of course, and you heard Ray really share the transition and the journey and how the clinic has evolved over time, because we've had to listen to the context of the organization and of course the backdrop of things like COVID and how that's influenced how we've approached the intervention and how we've delivered it. But of course, that's taken an extensive amount of resource, and a clinic like this of the size that it is within the trust and working across, of course, with King's College Hospital as well, has meant that we've had to really think about how we can do this in the most effective way. And it's utilised kind of three core resources: our researcher, our lead nurse, and a project manager within IMPHS. But there's been a wider team of people involved to make sure that we can actually deliver this to a high standard safely and effectively, and in such a way that doesn't actually hinder or burden existing organizational processes and procedures. And I think the challenge here for us has been often, of course, that we've also been very aware that this has been funded through the Maudsley charity for a short period. And Ray and Prash both mentioned, of course, that further work has had to be done to think about how we demonstrate the impact of this evaluation and the difference it's made so that we could actually go on and secure further funding so that it could be embedded into business as usual. And that journey continues for us, although we've had that 12-month period extended beyond delivery of this pilot. There's still some way to go. And I think that is an important thing for us to convey, that there's a continued evolution in this work. A few other things to mention, though, and these kind of latter three all kind of fit together, but I suppose to say that it was highlighted here, of course, about Ray and the individual kind of ability Ray brings to build relationships and to forge the kind of communication pathways to help others see the value in this intervention. And it's taken the particularly, I think, personal approach to be able to get into frontline services, to speak with peers and colleagues, and to really understand how we could get buy-in and how we could motivate people to find this to be a valuable support system for them in terms of how they're practicing and providing care. And the thing that's been important for us is actually not only doing that, but kind of really listening to people on the front line, understanding what they would find helpful, and then tailoring our approach to be able to be responsive to that. And that's taken a significant amount of flexibility. We've built relationships not only with staff, but service users and carers as well, because we've wanted to understand how the intervention could work for them and the difference that could make. And the ability to be adaptive within the organisation, I think, and hopefully it's come through today, that we feel that it's improved repeatedly. It's been a strengthened intervention as we've continued to evolve the thinking, and being able not only to establish the service in real time, but to think about contingencies in practice and how we could improve upon all of the different aspects of how we deliver it. And I suppose just very finally to say on this, that having processes in place, our standard operating procedure, which Ray mentioned right at the very beginning, you know, that has been something that as we've evolved the thinking has been robustly tested now. And I think there is a sense that we feel that we would like to think about how we can continue to scale an intervention like this and continue to gather data to continue to assess the impact. And not only that we want to do that in terms of the difference of quality of life outcomes it can generate for our service users, but actually what can it do in terms of the wider system. And Julie mentioned a bit about the economic impact that we're trying to really understand now, the value and the difference this can really make in terms of healthcare practice and making that much more efficient. So I think we wanted to be able to summarize for you what we've kind of feel are the key takeaways, and before we kind of bring the session kind of further to an end. So what we would like to do in this very final part is just give a moment to provide a bit of a Q&A. So it's an opportunity really for key speakers who have been with us. So Prash, Fiona, if you're still up with us in the room, Fiona, Ray, of course, and Julie, if you're able to come back onto screen for just a moment, it would be lovely to have you back. And it's an opportunity just for anybody else who may be in the room and may be interested to ask any direct questions to any one of us. I'll stop sharing the screen for just a moment so you can see everybody, just so that we can provide some space and time to do that. Welcome back, everybody. Just before I do that, just one comment in the chat, which is very nice. Melissa, thanks ever so much. More celebration of you, Ray. Also acknowledgement of that, which is always lovely. And well done to Julie and Ray. I think this is what is needed. Melissa says, Melissa's based at Lambeth and sees the value for this within our inpatient settings, which is lovely feedback. Thank you, Melissa, so very much. So just to say, if anybody does have any questions, please feel free to pop those in the chat. I know a couple of people have had to drop off and had some technical issues, so we are recording this, of course, so we can talk a bit more offline if there are things that people haven't had the chance to ask us here today. I do have a few questions, perhaps just to kind of put a few things to everybody who is here. I'm keen, Fiona, to come back to you first of all, if I may, of course, because you spoke so helpfully at the very beginning about the difference we hoped something like this would make and the real gap, the real need. In terms of the actual intervention and what we've been able to do through this pilot, I would love to get your reflections around what difference you think this intervention has made and could go on to make, you know, in terms of how we practice within SLAM in particular.
Well, I think it's been beautifully summed up by the team, including yourself beforehand, and Pratt as well, and also about that video from George. It's so much more helpful to be able to feel you've helped somebody get to grips with complex physical health as well as mental health difficulties whilst they're in hospital. You know, your mental health difficulties affect your physical health and very much vice versa. So taking a holistic approach to somebody in the same spot, it's really, really good for the patient. The carer, hopefully the carers and families feel that they are better looked after. And very much from the point of view of a practicing psychiatrist, having that senior support and be able to access Prash's wisdom about patients, it, you know, would have been fantastic when I was training, because just as George outlined, you move from a system where you're a junior doctor and you're really quite well supported in terms of the physical health needs of your patients, where into the mental health system, where actually, you know, people have whilst everybody is very well trained, they're not practicing every day in terms of the at a senior level, not practicing every day in terms of complex physical health matters. So it makes just so much more sense. It's better for patients, it's better for their families, it's better for the staff, and hopefully better, and we're trying to look at the data for this, for the acute hospital, general hospital staff as well, because just as Prash reflected earlier, he would have been seeing patients coming over that mightn't necessarily have needed to go across the road. And we are lucky it is only across the road, but for some people it could be miles and waiting for an ambulance and long journeys, etc. And if we can make sure that that is only used where people really need it, then I think it's very much better all round, better for the health service, better for the NHS, more economically sensible, and hopefully then that excess might be driven back into general care. So I think it's a win-win, and I think we've been very, very lucky to have such a fabulous team to implement it and to evaluate their implementation thereof.
Thank you so much, Fiona. And it's, I think you're right. There is something about being able to make sure we're sharing this learning and being able to really build on that thinking, because I think there is something here that we recognise as novel, and that, as you rightly said, Prash, as well, that the difference that can really make, you know, being able to know that you can address something that may be out of remit over here within the mental health trust, necessarily thinking about physical health. How do we do that in a way where people feel safe to be able to get advice, to be able to support patients? How do we do that? So it's really interesting, and I'm keen really to come across over to you, Ray, to ask you a question that kind of connects to this, which is, you talked a bit about the opportunity to spread and scale within SLAM, and of course the fact that we've secured funding to be able to do that. But my question to you is really about people that perhaps don't work within SLAM, that may be coming into listening to this today, that are thinking this is a really interesting intervention, there are clearly valuable outcomes here. How might we think about this if they were an external provider and be interested to think about the value of looking at physical health within a mental health setting? You know, what kind of advice would you have in terms of thinking a bit about the onward applications of a kind of an intervention like this and how people could learn from it?
I think there's a lot to learn from what we've done. I think there's a lot to learn from what others have done as well. One of the challenges that I said at the beginning of the presentation was that actually there's not a lot shared though about what happens in services. And you know, research is one way to share things, but there are other means of sharing, like for example this webinar. If we'd have had access to some more of these tools, it may have helped our thinking, how we develop the services, and how we, you know, how we approach things really. So one thing everybody can do is contact the IMPHS team after the webinar. We're very happy to speak to you about experience. The other thing though, as I said again at the beginning, is trying to get to the heart of that that local context, what's happening. For those that don't know where we're sat, today I'm actually not sat in the Maudsley Hospital, but Maudsley Hospital is literally on the other side of the road from King's College London. It's easier to throw a tennis ball across the road, you know, than walk across. It's that close. Yet the image that's shown is this Grand Canyon of you know, barriers, I guess, to accessing this care. So understanding that local context, and with that, I think as well, is figuring out, you know, what's important to people. And again, going back to the very beginning, speaking to patients, speaking to the carers, and speaking to the staff to understand, not just from, you know, how much is this going to cost, but how is it going to work? How is it going to get implemented? When do we need to review things? When do we need to evaluate things? And I think, you know, as we hand over the reins now back to SLAM Main, to Lambeth and Southwark, who have agreed to fund it, we'll be helping them to think through the next few phases of, you know, change and iteration, because the NHS moves. It's constantly changing, and so services like this need to be adaptive as well. And how do we continue to evidence the value of this sort of thing, so that they're funded for much longer than another 12 months, that they can be spread and scaled?
Great, thank you. And your kind of latter point there speaks to something I wanted to ask Julie, actually, which is about, you're completely right. How do we continue to really show the evaluation and the value of having that evaluation be done on an intervention like this, so that we can really see the impact in real time, and to inform any future development of the work? And Julie, just I want to give you, if I can, the final question, just really just if there is any sense from you about what difference that has made, being able to really evaluate this intervention, and any advice you may have for others who may be thinking about doing something similar.
Well, I mean, I think in the IMPHS team, we've been very lucky in that we've had this real great breadth of knowledge and skills and experience, from the clinical side to the academic side. And I think what's been great is working as a team, because it's been such a team. The whole of IMPHS has been a team thing, but this really has been. I think hopefully it shows the value of using kind of implementation science kind of methodologies, and really that's about planning and thinking about what you're doing and kind of thinking about what's the aim that we're trying to achieve, and actually how do we know if we've achieved it or not, and what do we need to do that. So I guess if there's anything I was going to say today, it's a plea to people to try and use those things, or even just thinking about planning things, you know, if you're going to implement anything new or make any changes to anything. And I know how busy people are in the NHS, it's really difficult for people to do that, but I think having someone like IMPHS with the kind of expertise that we've had, I hope shows the importance of having that kind of breadth of experience and knowledge. So thank you, Gracie.
Thank you all so very much, and I know we've kind of come nearly to time, so I'm going to end, if I can, the Q&A session there, and just a huge thanks to all of our speakers today. You've all been so fantastically kind and generous in sharing all of your views and opinions about this work, and really I suppose it's to say just at the very end here, IMPHS has delivered a plethora of different projects within its portfolio, and on the screen you can see that, of course, today is the 6th in a series of webinars we've delivered. For us, this is a moment to kind of say I guess thank you, because we've so enjoyed the opportunity to share our learning, and hopefully the fact that we've recorded every webinar is an opportunity for you to be able to go back and listen to what we've said, and to make sure that you haven't missed anything crucial. And if, of course, there are things you want to ask us, then please do get in touch with us. I've popped, of course, our details of how to reach us in the chat there. There is a QR code here for you, just in the event you would like to see the full range of our learning. We do have a report that is now available to download online, that you can see all of the projects in detail, which hopefully is an enjoyable read if it is of interest to you. Needless to say, we have come to the end of today's webinar, and just an enormous thank you to each and every one of you for spending the time listening to us. Please do get in touch with us if you are interested to talk more about this intervention at all, or anything we've covered in today's session. I'm going to stop sharing my screen now, and I will say, of course, if there are any final questions, I'll be here in the chat for a moment longer. But of course, otherwise, just a huge thank you, and I will leave you back to the rest of your day. Thank you very much. Take good care, all of you.